Hey folks, Scott Weingart here, and this is the MCRIT podcast. Specifically, this is the MCRIT RAC, Resuscitation and Acute Critical Care Literature Updates for January 2022. Before we get into it, just a customer service message. If you are having any trouble getting the private podcast feed on your phone or whatever device of choice you're trying to listen to, that shouldn't be happening. It's really easy. We can make it happen. If you get in touch with us at mcrit.org/contact, we will get you fixed up. There is no reason you should have to go to the website and individually listen to each episode after logging in. So if you're doing that, stop doing that. We'll fix you up. All right, let's get into the lit. All right, Journal of Trauma trial. Prospective, multi-center, East, good stuff. Looked at the reversal of antiplatelet agents and 10A agents, Zabans, to see if it conferred mortality benefit to do this reversal. And in this study, at least, it did not. It did not. Now, the platelet side of things goes along with the PATCH trial, looking at medical strokes, hemorrhagic strokes. Does reversal of platelets matter? And it didn't. In fact, it actually conferred an increase, a trend towards an increase in mortality. This trial would seem to indicate, and it's not really there yet to the level where I'd say definitively, but it would seem to indicate it may be the same for traumatic brain injury. And I think we could extrapolate that probably to any of the neurosurgically intervenable bleeds. The only one that may be different is aneurysmal subarachnoid, but who knows? It's just that that's a slightly different category in my mind. But this does go along with the big randomized PATCH trial. Now, I'm not saying make the change on your own in your clinical practice, but it may be worth having a conversation with your neurosurgeons, neurointensivists, and trauma surgeons all get to the table and say, do we really want to keep giving platelets? Now, slightly more difficult to ascertain what to do with result right now is it didn't seem to have any benefit to reverse 10A agents either in this trial. Now, this is a little bit more fraught. I think there's more variables here to really explore in terms of timing of last dose and what agents were actually used, but it is of interest as well. All right. The Proper 3 RCT confirms that fixed dose PCC is non-inferior to the manufacturer recommended, which almost always results in giving larger amounts of PCC dosing. This was in the Annals of Emergency Medicine, and they were using 1,000 units of PCC versus the manufacturer Rex, which would be, Kcentra in the United States. I think it's similar in most of the places. And the fixed dose seemed to do just fine. And this is what we've been doing for a while, is we just keep a 1,500 of this in our fridge. And in fact, on bad bleeds, we've been giving the 1,500. We might, on lower INRs, actually just give 1,000 based on the results of this trial. But having the 2 boxes there in your ED and just giving it and not having to wait for an INR is game-changing. And you can always check the INR 10 minutes after the infusion is completed. And if their INR is still up, now you have room to give additional PCC if the initial dose is not where the manufacturer recommended dose would have been. So it saves a lot of money. There's less annoyance having to mix up multiple boxes. So I think this is just good all around, and I've been doing this for years. All right. This one, I've finally been waiting for someone to study it because it's pissed me off that I know this is the case, and yet there's not great trials to indicate it. And I think most of the current trained generation of EM already knows this, but there's some old timers out there. We love you, good for you. But they're still doing crap like this. And it's a trial on the adverse events associated with flumazenil to reverse benzodiazepines. Now, and when I say old timers, they're generally not EM trained old timers. They're intensivists and maybe people that have grandfathered in but have not gotten a real good education in EM. Wow, I'm probably pissing people off left and right. I'm sorry. If you're listening to MCRAT, chances are this has no applicability to you because you wouldn't be doing this. But it's bad. It's bad to reverse benzos with flumazenil. Don't do it. Don't do it. Just don't do it. You can read the article here in Toxicology, but just don't do it. All right, next up. A comparison of push-dose pressors, epi versus phenylephrine. Now, there's many cool things to take from this, and you can look into it if you're interested in more of the specifics. But the key for me is that epi did not significantly increase heart rate, which means Cliff Reed was right all along. When he told me probably 14 years ago, there's no reason to have multiple push-dose pressors. You're an idiot. Why are you making things complicated? Just use epi for everything. And I'm like, well, what about AFib? I'd like to have, the style points for using something that's not going to increase the heart rate. Well, guess what? Epi doesn't increase the heart rate with any significance when used as a push-dose agent. And therefore, you can now go to just one for your entire department. So There you go. And that was the American Journal of Emergency Medicine. All right. Next up, also in the American Journal of Emergency Medicine, a trial comparing labetalol and other push-dose antihypertensives to nicardipine, an infusion antihypertensive, to lower the BP before the administration of TPA for stroke. Now, I'm not going to get into whether TPA actually works for stroke. That's an argument for a different day. I will say if you're going to give it, it should be given as quickly as humanly possible. So if you're committed to it and you want to bring the blood pressure down, then my feeling is you should use nicardipine. Now, this trial would say, you're not going to have any difference between nicardipine or labetalol. And when you look at how they use the nicardipine, it's obvious why. And I totally agree with the trial's results. If you use nicardipine the way the manufacturer recommends, it's going to be the same or maybe even slower than labetalol, even though labetalol is a homeopathic agent with like very little effect. And why is that? Because you can't use nicardipine that way. You need to rapidly titrate up to 12.5, 15 milligrams per hour of your nicardipine. And then as you start getting closer to your goal BP, less than 180, 185 technically, but come on, because you're going to maintain them at 180. So it should be 180. Less than 180, as you get closer, as you're like at 200, 190, and you're getting in that range, then you dial it back. Once you get below that range, you drop it all the way. You drop it down to 3 milligrams, and then you will have a incredibly rapid nicardipine. Like it doesn't take me longer than 10 minutes for any patient that I can remember in like the past 5 years using that form of nicardipine. Now, the way we really should be doing nicardipine is we should be given pushes of it, but that would be a great trial for someone to do. It's absolutely safe. You're giving the exact same amount as you'd be giving if you were giving it at the 15 milligrams per hour at a minute-by-minute basis, but then it would be even more rapid. And then you wouldn't have to worry about all this pulling back crap. You could just start the drip at 3 milligrams and push the nicardipine until the BP is close to where you want, and you'd be in very, very good shape. And then you could titrate up from there to maintain. But in this trial, using nicardipine the way the manufacturer recommends, no difference, and doesn't surprise me at all. Okay, now another one that doesn't surprise me at all, and I've been pushing for this to happen, is tenecteplase gets in thrombolytics in stroke much quicker than alteplase. And this is obvious, right? I mean, the mixing, the checking, the crapping, it's ridiculous. Every piece of evidence says TNK is at least as good. I think we should all be switching to TNK for stroke if we're going to give thrombolytics. And again, not going to get into the argument of whether we should give lytics at all in stroke. That's an argument for a different day. You already know my stance on it. If not, you can check EMCrit. There's like tons of crap on it. All right. Back to epi. This was in the BMJ, and they looked at shockable rhythms. What happens when you delay the shock to give epi? And the answer is patients do worse. If epi is going to work at all in resuscitation from cardiac arrest, it's probably in your asystole PEA patients. And I'm not saying don't give it in a shockable rhythm, but your first move, the move you should be optimizing everything towards making happen, is shocking the patient. Then after that first shock, if it doesn't work, then you can consider giving medications. All right. This is not one specific article. This is I think upwards of a dozen articles now, which is that metabolic cocktails don't work for sepsis. And, Paul Marik really pushed hard on this based on his observational trial. And as a result, people around the world did very well-designed randomized controlled trial, and it doesn't work. HAT doesn't work. Metabolic cocktails don't work. Don't give cocktails at work. It's not the place to drink. Give cocktails at the bar. No cocktails, stop. Paul Marik has recently resigned from his position at the Eastern Virginia Medical School due, I think, a lot pertaining to the COVID-19 stuff and his frontline critical care group. But what I could say definitively is that the metabolic cocktail doesn't work. And the only trials that indicated benefit were the ones that compared the cocktail versus placebo. And in those trials, the patient got steroids as part of the cocktail versus the trials that looked at steroids as the comparator group versus steroids plus, the thiamine and the vitamin C, no benefit whatsoever, which would lead me to think, which we all kind of know, that steroids probably still have a role in septic shock. Now, as to what that exact role is, it's tough to say. I still give them when I hit now around 10 of norepinephrine, I'm giving steroids. But if there's any part of the cocktail that works, that's it. All right, this one's fun. It came to me from the journal feed of emergency medicine, and it's the effectiveness of the intradermal sterile water injection for low back pain. Now, this is not critical care, but I just love this so much. And what they did, in contradistinction to trigger points, which I've also found a marked efficacy, I think mainly due to placebo effect and maybe some needling effects on the local muscle tissue, but this was intradermal. Like, the same way you get a TB MAN2 shot, it's really not even penetrating down to the muscle. And if you put a square of 4 of these little intradermal injections of saline around the area of maximal pain and the back pain, patients loved it. They did much better. Wow, is this a great way to get patients out of the department for a procedure that takes less than 30 seconds, really makes them feel you care and you did something. And if you keep getting into their heads that this is what your response to low back pain is going to be, that you've deemed to be non-acute and non-emergent, maybe they'll seek help elsewhere. And they'll get pain relief from this. This is not, shunting patients off to a garbage therapy. They actually got marked relief in their pain. So this is a great way to go. All right. Second to last, sensitivity of multi-slice CTs for subarachnoids at incremental time points, a 10-year analysis, Emergency Medicine Journal. Interesting here is that still out to 24 hours with the current generation of the CT scan, it's 100% sensitivity for subarachnoid. No LP needed if you believe those results. Now, I'm not saying believe them yet. Don't do this. Don't do this yet. Don't do this yet. Wait for your nation's emergency medicine group of record to actually say this is cool. But this does allow you, if you're having a conversation about LP with your patients, to tell them, like, we have this one trial, shows perfect sensitivity. I mean, you translate this to non-medical ease. Do you still want the LP? Do you still want a needle in your back? Last but not least, equilibrating surviving sepsis campaign guidelines with individualized care. This had Jean-Louis Vincent, Mervyn Singer, and a host of other luminaries in the critical care world all saying the same thing, which is we can't use guidelines to legislate our care. And they have multiple suggestions for areas where the guidelines should allow lenience based on your individual patient in front of you. This is obvious. This needs to happen. It's stupid that it's not. These guidelines should be guidelines, meaning here's one pathway to care if you're not very good yet, if you're not very experienced yet. And they're guidelines, and you don't have to do them. You just use them as guidelines, and you diverge from them as needed based on your patient in front of you. That's how we're supposed to be taking care of patients. Whew. Scott Weingart from the EMCrit Rack Lit Update, January 2022, saying